Scholar Blog presentation is on the primary impingement of the shoulder, and it is created and narrated by Tyler Burnett and McCade Powell. Shoulder impingement syndrome is a condition where your shoulder's rotator cuff tendons and other structures are intermittently trapped and compressed during shoulder movements. This causes injury to the shoulder tendons and bursa, resulting in painful shoulder movements. There's two main types of shoulder impingement, primary and secondary. In this presentation, we're just going to focus on primary shoulder impingement. This is a result of anatomical or biomechanical factors which decrease the space between the humeral head and the acromial arch, thus causing compression of some of these structures we already mentioned. In comparison, secondary shoulder impingement is more of a dynamic instability. In 1972, Neer first introduced the concept of rotator cuff impingement to literature. In the process of doing so, he created three different stages which were dependent on the involvement of the underlying tissues and the severity of this condition. Stage 1 can be characterized as edema and hemorrhage, and usually a younger patient demographic. And in this stage, you can first observe the painful arc of motion between 60 and 120 degrees of scaption. Stage 2, you have more of a fibrosis and tendinitis, and a mild to moderate pain with overhead activities. This pain can often interfere with individuals' ADLs, sleep, and overall quality of life. Stage 3, you'll see a true rotator cuff tear and even biceps tendon involvement. These individuals often complain of pain at rest, and it's usually a little older of a patient population. Significant tendon degeneration is a hallmark sign of stage 3 impingement. So looking more into the general anatomy and the pathogenesis of the condition, there are both intrinsic factors and extrinsic factors that can cause impingement. Intrinsic factors include bony abnormalities, vascularity of rotator cuff tendon, and degenerative changes, whereas extrinsic factors include muscle imbalances, postural changes, occupation, and the level of activity or type of sport these individuals play. Shoulder impingement can be viewed as one of the more prevalent conditions affecting the upper extremities. It accounts for more than 44% of shoulder disorders. It is most commonly seen in individuals greater than 40 years old, and especially in association with repetitive overhead arm movements. We're now going to take a look at the diagnosis of primary shoulder impingement. Just like any other clinical condition, you first want to take a good history and physical examination. This history will help you determine what special tests you'll later perform. For the physical examination, you're going to objectively collect data, just like any other condition, such as active range of motion, passive range of motion, muscle strength, etc. It's important that during all these shoulder movements, you're taking a look at the scapulohumeral rhythm and appreciating any dyskinesis if it's evident. It's also important to take a look at the patient's posture as well as their muscle length. Special tests can often help you rule in shoulder impingement. They include the Neer test, the Hawkins-Kennedy impingement test, as well as the crossbody adduction test, which also can take a look at the AC joint involvement, but is a good indicator of shoulder impingement as well. Resistive testing is also a good idea to get a better understanding of the integrity and involvement of the rotator cuff musculotendinous structures. You can take a look at the integrity of the supraspinatus musculotendinous unit by doing the full can and empty can test, as well as the drop arm test. You can also look at the integrity of the infraspinatus muscle and tendon by performing the external rotation resistance in neutral. Moving forward, you can check the integrity of the teres minor muscle by performing the Hornblower sign test. And finally, you can perform the liftoff test or the belly press test to see if there's any subscapularis involvement with the impingement. Imaging studies are also a good way to take a look at possible primary shoulder impingement. MRIs are useful in identifying the severity of the injury, such as rotator cuff tendon damage. X-rays can also be useful in identifying acromial-humeral interval, which is indicative of the degenerative joint changes, subacromial bone spurring, if there's any at all, and they also take a look at acromial morphology, such as type 1, type 2, and type 3 acromion, with type 1 being the flattest type of acromion and least likely to be impinged upon, and type 3 being most closely linked to shoulder impingement. An individual's signs and symptoms can align with the progressive process in the deterioration of the rotator cuff tissues. Thus, you can use these signs and symptoms to kind of give an idea of what stage they are in. In stage 1, patients will often experience a tenderness at the supraspinatus insertion and anterior acromion. They'll often have a painful arc that we already discussed, and there will be a general weakness of rotator cuff tendons and muscles, which is secondary to pain. They'll have a general decrease in active and passive range of motion. In stage 2, patients will often experience pain at the top of the shoulder that can radiate as far down as the distal deltoid insertion. They'll often complain of a stiff shoulder, and crepitus can often be appreciated at about 100 degrees of glenohumeral elevation. Stage 3, there's a localized atrophy, which is usually affecting the supraspinatus and infraspinatus structures, an increase in the level of pain, which can even be painful at rest, and even more loss of active and passive range of motion. So listed below are some of the more common findings of individuals presenting with primary shoulder impingement. You often see positive Neer and Hawkins-Kennedy impingement tests, as well as positive rotator cuff resistive tests dependent on the involved musculotendinous units. There'll be a decreased active and passive range of motion, as well as a painful arc between 60 and 120 degrees of glenohumeral elevation. Individuals will often have rotator cuff weakness secondary to pain in stages 1 and even 2, and even true rotator cuff weakness due to atrophy associated with stage 3 can be observed. Patients will have a history of repetitive overhead activities, as well as they'll often experience impaired posture and scapular dyskinesis. Finally, patients often complain of clicking, catching, and grinding, especially during shoulder elevation.
When a patient with the common clinical patterns just discussed presents to your clinic, here are some interventions to address their individual needs. During stage 1 impingement, the focus is to control pain and inflammation. Tell the patient to rest and modify activities as needed to avoid making the impingement worse. It is important to educate the patient about what is happening in their shoulder. Progression of impingement can lead to a worsening of symptoms and possibly partial or even full thickness tears of the rotator cuff tendons. With a patient suffering from stage 2 impingement, it is important to focus on a progressive strengthening program of the rotator cuff muscles to help improve the stability of the shoulder during shoulder elevation. Neuromuscular control or re-education is another possible intervention that may be needed to address the underlying issue. A patient suffering from stage 3 impingement probably realizes that their arm strength and movement has changed considerably. To help them regain strength and motion, focus first on scapulothoracic strengthening and scaption retraining, followed by rotator cuff strengthening. Start with isometric exercises, progressing to closed chain, and then open chain exercises. As a general overview of interventions, be sure to restore range of motion and strength of the surrounding muscles. Don't forget to address proper scapulothoracic motion, as well as the thoracic spine and other involved joints. Through effective history and physical examination, you will know how to treat the impairment and underlying problem. Individuals suffering from primary shoulder impingement generally have a good prognosis for recovery with conservative physical therapy interventions. At least 2 studies found that exercise supervised by a physical therapist was as effective as surgical intervention combined with post-operative rehabilitation for patients with stage 2 primary impingement. Another study reported improved range of motion, decreased pain, and increased function in patients with shoulder pain who underwent a program of individualized muscle stretching, strengthening, and retraining versus surgery. However, it is estimated that 15 to 28% of patients who fail to make satisfactory improvements over a period of 6 months may eventually require surgery. Possible complications leading to this recommendation could include chronically inflamed rotator cuff tendons, frozen shoulder or loss of motion, rotator cuff tendon tear, and/or recurrence of signs and symptoms. When using outcome measures, you will be most effective if you ask yourself why you are using it and what you are aiming to measure. For example, you may use an outcomes measure to identify the impact of a disorder on an individual, establish a baseline measure from which to monitor changes over time, or evaluate the impact of an intervention. Outcome measures can be used to measure impairments of body structure and function, activity limitations, participation restrictions, and/or the quality of life. Outcome measures such as the DASH, UCLA Shoulder Scale, the Simple Shoulder Test, and Shoulder Pain and Disability Index are specific to the arm and shoulder area. The better you know the outcomes measure, the better you can know your patient and the effect of treatment.